It's working good. All right, that's just a little something to wake everybody up. All right, my name's Brad Edgren, and today I'm going to talk to you a little bit about Cbct and modern bioprogressive treatment. I am from Greeley, which is an hour north of Denver, and that's the view from Greeley towards the mountains. So we're on the plains. A lot of farm country. I'm a graduate of the University of Iowa Dental Program and the University of Iowa Orthodontic Program. I believe that the first key to orthodontics is your diagnosis. You can't treat what you don't diagnose, and you can't diagnose what you don't know. And I believe that a proper and thorough diagnosis dovetails into the mission of bioprogressive therapy, which is designed around the total treatment of the face, rather than the narrow objective of treating just the teeth and or the occlusion. I feel that today many orthodontists focus on the speed of treatment, yet ignore the overall outcome for their patients because their focus is on the dentition. They fail to take the patient's skeletal components into account. So there's 10 basic principles to bioprogressive therapy. They are assistance approach to diagnosis treatment planning, torque control throughout treatment, muscular and cortical bone anchorage, movement of all teeth in any direction with the proper application of force, dental facial orthopedics, overbite correction, then overjet, sectional therapy, concept of overtreatment, unlocking the malocclusion, and then efficiency of treatment with quality results. Now, bioprogressive therapy has a systems approach to diagnosis, and Ricketts always talked about a systems approach to orthodontic treatment. So a systems approach to diagnosis includes a clinical exam. Now, I know many of you are thinking this only makes sense. However, I've had more than one patient come into my office for second, third, or even fourth opinion. And the opinions they'd received before were based mainly upon a bad panoramic radiograph, and they'd never even met the patient. These opinions without the clinical exams included extraction of permanent teeth at a very early age without any regards towards future dental facial growth. Photos, models, I do mount all of my cases. And then radiographic imaging. And imaging is a key component to understanding the full story of a patient's anatomy, and without it, I think you're going to be missing quite a bit. But if we're going to be discussing modern bioprogressive therapy, radiographic imaging now includes Cbct imaging. So with Cbct imaging, you get all sorts of information off of one scan. And these are just some of the images provided by a single Cbct image. And a single scan provides both a lateral and frontal cephalogram. And remember, Broadbent was the first to introduce us to the cephalometric radiographs in 1931. And he took both his lateral and frontal cephalograms simultaneously. And many orthodontists don't even look at a lateral yet, let alone a frontal cephalogram anymore. And with Cbct imaging, you have both images available for cephalometric analysis. And if you're using Cbct imaging, I believe you should be doing a frontal and lateral analysis on every single orthodontic patient. It's the only way to make full use of the information available with a Cbct scan. Another benefit from Cbct scan imaging is that even after the scan is taken, the patient's head orientation can be adjusted to minimize positional errors in the lateral and frontal cephalometric analysis. Another advantage of Cbct is the ability to volumetrically superimpose scans to evaluate growth and treatment outcomes. So applications of Cbct imaging include three-dimensional orthodontic treatment planning, orthodontic surgery treatment planning, implant planning, and I'll tell you, if you're planning tooth replacement via an implant for your patients, you really should be using a Cbct scan. I can't tell you how many patients have come into my office via referral from the oral surgeon for a Cbct scan, and their orthodontist didn't leave enough room for implant placement. 3D visualization of dental impactions, and if you're not using CBCT for that, I would highly recommend it. Periodontal disease, periapical pathologies, trauma pathology, TMJ analysis, airway volume analysis, sinus evaluation, and finally informed consent in patient education. Cephalometric analysis, you should be doing a lateral and frontal on every patient, and yes, you should be doing a growth analysis. It's the fourth dimension. If you're not taking the time to do that, I think you'll find that your cases later on, you're going to have failures because you didn't take growth into account. I can't tell you how many patients have come into my office from other offices that included permanent tooth extractions and would have ended up in anterior or posterior crossbites because they didn't take growth into account. This is a perfect example of a patient that's presented in my office. She outgrew her orthodontic treatment. She had upper first bicuspids removed. She's now 31 years of age, open bite, periodontal issues, myofascial pain disorder, headaches, posterior and anterior crossbites. This was an online poll and taken a year ago, and I realized there's only 77 votes on this, but only 19% of the orthodontists were tracing 100% of their lateral cephs. I think that's really a poor number. And if you look down here, over 55% of them were tracing less than 20% of their cephs. I think that if you're not doing a cephalometric analysis, you're doing yourself and the patient a disservice. There was an article written by McCabe and Reinkus in Orthodontic Practice Journal back in January and February. And they did a survey of orthodontic practitioners regarding the routine use of the lateral cephalometric radiographs in orthodontic treatment. Conclusions were 60% of the orthodontists reported taking a pre-treatment lateral ceph, but only 38% reported actually tracing it. And then at the end, only 30% actually took a final lateral ceph. And I feel that if you routinely use cephalometrics on your patients, it's a reset so that you can constantly evaluate your patients with clear optics. Your clinical bias then is reduced. Moreover, 82% of the orthodontists would believe what they see in the mouth, which is the clinical findings, over what their cephalometric analysis revealed. However, the last article didn't even talk about frontal cephalometric analysis. I'm sure that the percentages of orthodontists taking a routine frontal ceph is at best in the low single digits. This is a continuing education piece I wrote on the frontal analysis back in the October 2013 edition of Orthodontic Practice. And in my article, I discussed the importance of the frontal analysis and its benefits. And one of the things it talks about is skeletal lingual crossbites. And I was taught that a frontal, when I was in school, was only necessary if the patient had an obvious dental crossbite. As a result, we hardly ever took frontal cephs. Consequently, my fellow residents would place their thumb in the palate of their patient's models to determine if the patient needed maxillary expansion. However, what's important to understand is that not all patients have obvious crossbites or transverse discrepancies resulting in dental crossbites, and the frontal analysis is a better judge of skeletal constrictions in the width of your thumb. So if you're not routinely performing a frontal analysis on your patients, you will fail to notice all but the most obvious of constricted arch forms. Performing a routine analysis on all patients provides a constant reset to what is normal and what's abnormal. So in this study, using cone beam computed tomography by Miner and others, they concluded that patients may indeed have skeletal lingual crossbite patterns without obvious dental crossbites, and these patients might require treatment for these significant constrictions and discrepancies. They found that dental inclinations and compensations mask transverse discrepancies. Once again, the benefit of a frontal analysis is the ability to diagnose those patients who have skeletal lingual crossbite patterns, as well as those who would benefit from maxillary expansion. So, there are additional benefits from a frontal analysis other than just looking at dental and skeletal widths. Frontal analysis helps in diagnosing skeletal asymmetries, nasal widths, and turbinate enlargement. And I want you to think about this. With those patients that are mouth breathers and you remove the tonsils and adenoids, but the nasal cavity is still narrow, or the turbinates are significantly large, your patient's still going to breathe through their mouth. As a result, the negative effects of mouth breathing on dental facial growth will still occur unless the nasal cavity obstruction is addressed. And the nasal cavity can only be evaluated from a frontal ceph. It can't be evaluated from a lateral. Angulation of impacted teeth, yes, you can see the angulation of impacted teeth from a frontal. Dental midlines, occlusal cants, and pathology. Oh, and by the way, our patients make their smile assessment, which is made in the mirror from the facial perspective. It's also the same perspective by which he or she will ultimately decide if our orthodontic treatment is a success or a failure. So why don't orthodontists use the lateral frontal analysis more? I think the answer is the same as why don't orthodontists take more laterals. It's too hard, it's an expense, and they might think it's not necessary because no one stressed its importance. Unfortunately, they're missing about 50% of the patient's orthodontic diagnosis. So in my opinion, if the frontal analysis is not important, then neither is the lateral. So I don't know about the experience of everybody in the room has had with CBCT, and so in an effort to bring everyone up to speed, I'm going to spend the next few minutes comparing and contrasting the differences between cone beam scans to traditional radiographic imaging. Moreover, I'll be using examples of how CBCT was critical in diagnosing patients' conditions as we proceed. So here's some examples of intraoral imaging uses or advantages. It's cost efficient, it's got high resolution, it's good for caries detection. There's the limitations, it's only two-dimensional. Magnification errors affects measurements, and for some, it's not real useful for viewing certain pathologies. So here's a patient that presented into my office for orthodontic treatment. And you'll note that the patient has a root canal in the upper left central. The obturation of it looks a little suspect to me off of this pan. And obviously the patient's taken a blow to the face in the past, requiring a root canal as a result of the accident. One of the benefits of CBCT is the power of slices. Let me back that up. And, you know, as an orthodontist, we can only look at the teeth. Not only can you look at the teeth buccolingually, but with CBCT, we can also evaluate the teeth mesial-distally. And so in this patient, he's got two different problems going on. And zooming in on the images, you're going to note that this patient has a horizontal root fracture on the upper right central. The left central demonstrates a buccal perforation from the obturation of the root canal. So both of these situations are obviously not good for the orthodontist. However, the fact that these problems were picked up prior to starting orthodontic treatment lends itself to what I was talking about before, informed consent. Can you imagine if this wasn't diagnosed before treatment started? How many think the orthodontist is going to get blamed for root resorption? Every single time the orthodontist is going to get blamed. In this situation, obviously, the problem here was the blow to the face, not the orthodontics if there was resorption. Here's a transfer case that came into my office. They'd been in fixed appliances for 3 years. 4 bicuspids were extracted, and she has a lot of problems. I want to point this out. She's got a number of wire ties going on here. She's got wire ties on lingual buttons on the lower right. You'll notice the skewed arch form. Open bite. Brackets on some teeth, not others. And I'm telling you, this is a case that should have had progress records taken on this patient prior to them ever coming into my office. And there's another view of her open bite. So if you look at her lateral ceph, it demonstrates a severe skeletal class 3 with an anterior open bite. Looking at the panoramic image, you'll start to notice that she has a radiolucency surrounding her radial opacity. And this lesion's been there for some time. Looking at some of the cross-sectional slices that you can get with CBCT, clearly you can see that the lesion is right there, and it's on the facial. You can also notice the skewed dental arch form. Working around the arch, you can see this lesion here. So the biopsy confirmed fibrous dysplasia, which likely ankylosed the mandibular right canine. Consequently, the ankylosed canine and the mechanics that were employed caused a severely skewed arch form, and this. Lower first molar, we talk about buccal root torque. It's been pushed out of the ovulus. Second molar is worse. So, zooming in, you can see the second molar has been pushed out of the alveolus, but don't lose focus on just the second molar, or don't lose focus on the rest of the case, I should say. The first molar has been being pushed through the root, through the buccal cortex. So what happened? Well, ankylosed right mandibular canine locked and torqued the lower arch, including the mandibular molars, pushing them through the buccal plate, and crossbite elastics couldn't overcome the mandibular buccal root torque and push the first molar through on the buccal as well. So this is the case that illustrates why I always take my own records on patients before I start orthodontic treatment. I always do. And this was a very good situation whereby Cbct imaging is good for patient education and informed consent, because now the patient knows what we're facing. And we also have problems with the upper left first molar as well. So tomography, at the time, it was very useful for imaging of the condyles, reduced superimposition of adjacent structures. Limitations, it's time intensive, requires an SMV and multiple exposures to get these type of images. This is another interesting case that's already undergone phase 1 treatment elsewhere, including extraction of the maxillary first bicuspids. It's a corrected severe skeletal class 2 due to the mandible. In the submental vertex view, notice the severe mandibular asymmetry. Lower jaw is asymmetrically positioned off to the patient's right. And asymmetries like this can be evaluated immediately after taking a scan. You'll also note that the inferior borders of the mandible don't line up with each other. Now I realize that a traditional Ceph with that a mandibular skeletal asymmetry can be diagnosed this way. However, obviously in this case it wasn't diagnosed because of it. Instead of addressing the asymmetry, the upper two bicuspids were extracted, when in fact this is a surgical case. Here's a panoramic image, and you'll note her right condyle and ramus are significantly shorter than the left. And here's a tomographic imaging. In these images, you can see there's a significant difference in the volume and mass of the two condyles. And that's what the result of, that's causing this skeletal asymmetry. You'll note the poor condylar form of the right side compared to the left. So, moving forward, talking about panoramic imaging, looking at traditional panoramic imaging, the focal trough or image layer needs to lie between the source of the radiation and the film or receptor. If the arch form is relatively perfect and the patient's oriented just right and the focal trough's lined up exactly on the money, the resulting panoramic image will be usable. However, with our patients that have severe skeletal discrepancies, horrible malocclusions, and significant crowding, they don't have perfect alignment, and as a result, the focal trough can't be aligned properly. Consequently, the panoramic image is poor and undiagnostic. An undiagnostic panoramic image leads to poor decision-making, resulting in bad treatment planning and bad orthodontics. So this is a pan of one of my patients from a few years ago, prior to having a Cbct scanner, and I was waiting for the eruption of the remaining permanent teeth. And one of the advantages of panoramic imaging, it does give you an overall view, suitable for visualization of both jaws. But as I said before, it's got some limitations because of magnification and distortions that result in unreliable information. And those distortions vary throughout the panoramic image depending upon the patient positioning. You also get anatopical features of interest that lie outside the focal trough. You get overlapping of teeth, especially in the bicuspid region. Anteriors register poorly when significantly proclined, and artifacts can be easily misinterpreted. So here's the same patient about 18 months later, and note that we have a maxillary second molar that refuses to erupt in only 3/3, or do we? And once again with Cbct, it shows power slices. You can see that this patient has 4/3 molars and the maxillary right third is impeding the eruption of the maxillary second. And And zooming in, you can see the position of the third molar. This was a patient that just came into my office for a second opinion. They carried in this scan with this pan with them. And I think it really illustrates the amount of distortion that's going on with just this pan. Maxillary canines appears there was no room for eruption. Even the maxillary lateral incisors look like they're blocked out. And previous clinician's treatment plan on this young patient was to extract deciduous laterals and canines and then wait to do treatment later. When they consented to doing treatment, I took a scan on them, and you can see how the bicuspids, everything looks a lot clearer. And you'll note that this patient, this is just some imaging of the left side. You'll note that this patient's in crossbite. But the other thing that's interesting is that you can see the angulation of these bicuspids and how they're lingually oriented. So artifacts can be easily misinterpreted. This happened to be a case that I had discussion with an oral surgeon last week, and the patient's dentist is concerned about this radiolucency surrounding a radiopacity in the mandible. So this was taken a year ago. Same patient. And that pan was taken in February. So the patient comes into my office as a referral from the oral surgeon. There's nothing there. So obviously, it's not something in the mandible. So here's a video representation of her scan. Does anybody see it? It's got a heart. It's right there. Lateral image. It's right there. There it is. So it's not in the mandible. It's probably a tonsillith, and the oral surgeon is going to refer her to an ENT to have them take a look at this. But this just shows you how artifacts can be misinterpreted on a pan. So while the panoramic is one of the most common views in dentistry, it's also the most distorted and should be interpreted with extreme caution. For assessment of tooth positions in orthodontics, all 7 scientific papers on this topic conclude a panoramic is highly unreliable for the assessment of root tip and root parallelism. Yet this practice remains relatively common in orthodontic practices. This was a quote from Ma. American Board of Orthodontics relies heavily upon a panoramic image to grade final outcomes of cases, and yet it's frequently distorted. I remember having to grade my final results based upon a retention pan, and I would have to deduct a point here or there because my canine root tips appeared not to be parallel with the first molars, even though I believed it was distortion inherent in the panoramic image. However, root parallelism is a minor complication compared to other more serious concerns. This is another patient of mine. Motor vehicle accident 10 days prior to the scan. And I think this is a situation where the panoramic image doesn't tell the whole story. Many of you are probably going, okay, he's been in, he's had a repair here. He had a goose egg underneath his chin when he came into the office, and I was actually milking it, and we were getting pus to come out between the teeth, in the front or the bottom. Now you probably are saying, okay, they repaired that, and obviously, he says, my jaw doesn't feel right. Well, yeah, he's got a fracture right there. Okay, but the thing is, as I was saying about panoramic imaging, they missed that fracture too. It's got a telescoping subcondylar fracture of the left condyle, and by this point in time, it had already healed in that position. We sent him to Denver to try and get that to reapproximate the broken margins, and it didn't work out so well. Another patient just transferred into my office has had 4 bicuspids extracted. I took this pan a couple of weeks ago. The teeth were extracted back before Christmas time, and nothing was done to address the closing of the spaces before he came in to see me. think you can see that there's a lack of bone at the extraction sites. No buccal plate, especially up here. As the scan turns around, you notice that there's daylight all the way through. Oh. So cephalometric imaging, it's good for orthodontics and airway evaluation. Limitations: clarity is restricted, lack of accuracy in measurements due to superimpositions and magnification, and you get false asymmetries due to patient positioning. So the orthodontic record, consisting of a lateral ceph and a panoramic, is severely limited in the volume of information it provides, and is lacking in the ability to reveal subtle asymmetries, dental details such as root anatomy and torque, limitations of alveolar width, relation to soft tissue of the face, status of the temporomandibular joints and airways. So it's foolish to think that CBCT imaging is only indicated if something's detected on a panoramic or lateral ceph, since both these images lack diagnostic specificity and sensitivity compared to CBCT imaging. Given the clear advantages of CBCT imaging, the potential benefits of detailed information, the proper diagnosis and treatment planning, it's clearly the modality of choice for comprehensive orthodontics. I wish I'd written this. This kind of proves my point about imaging. This is another patient transferred to my office. She had appliances on the upper arch. She's 24 years of age. Couldn't continue with treatment at this point in time due to lack of funds. So they requested removal of the appliances, and I said, based upon what your mouth looks like, we're missing teeth down here, not quite sure what's going on down here. We've got a bombed out tooth. I recommended taking a scan. Now I set this pan up because I think this pan is probably something that the previous clinician would have taken, and this is what he would have seen if he had taken a pan. Here's a lateral. If they'd taken a lateral, you can see she's almost vertical. But with CBCT imaging, you start seeing things that you didn't see before. And you'll see with this patient, she's got impacted lower central and lateral incisors with an odontoma or supernumerary preventing the eruption of the teeth. And this is something they were unaware of. So once again, if you don't have a CBCT machine, this is why I always recommend taking a frontal analysis and frontal cephalogram on all patients. So airway obstruction, dental skeletal asymmetries, transverse discrepancies, missing teeth, alveolar bone deformities, endodontic pathology, oral pathology, impacted teeth, root torque. These are all just some of the things that you can evaluate from a scan. So what I'd like to do is run through a few cases showing how CBCT shines and augments in bioprogressive therapy. This is a 7.5-year-old patient of mine presenting with a right posterior crossbite, complete anterior crossbite, no incisor displayed smile, and also note her extended neck posture. She's a mouth breather and has difficulty breathing, hence the need to extend her neck to breathe, open her airway. She also experiences chronic halitosis from tonsillar hypertrophy and tonsillitis. So if you look at her from the side, you can see she's in a complete posterior crossbite, complete anterior crossbite. Note the deep underbite and the diastema. So here's her diagnostic scan. And she had just gotten her ears pierced, so that's why the earrings are in there. She didn't want to take them out. There's a panoramic image. You can note the ectopic canines, and I especially don't like this right canine where it's coming down on the lateral. Here's some of the cross-sectional slices. You can see that the upper first molar is in complete crossbite. And notice that the orientation of it is nearly vertical. A very good example of maxillary transverse discrepancy. And there's the cross-sectionals visualizing the incisors. Note the position of maxillary incisors in that alveolus. They're forward in it. So if you unlock the maxilla by correcting the anterior crossbite, then we're going to get some normal maxillary horizontal growth. So there's her lateral ceph. And the other thing I want you to see is note the curvature of her spine, her cervical spine. And this is a three-dimensional airway analysis of her airway. You'll notice it's black and red. It's down here at the bad end of the spectrum. We want these patients up here. Here's her frontal. And this is her airway from the front. Once again, notice black and red. So I send all my cases into Rocky Mountain Data Services. Done that for the past 20 years. I do a frontal and lateral analysis on every single patient, intergrowth analysis on the growing ones. So she's got a potential skeletal class 3 to the mandible, skeletal-lingual crossbite pattern, just as we suspected. Airway analysis comes back that she's got adenoid blockage of the airway. So here's her lateral ceph. And I evaluate all my patients using Ricketts visual norms. I find it easier to use visual norms to communicate with my patients and parents about their orthodontic problems than verbally explaining what the numbers mean. And since 90% of learning is visual, these visual norms help convey the orthodontic problems as clearly as possible. And with this patient, note the protrusive maxilla and the prognathic mandible. Here's her growth analysis. You notice she's got about 8 years of growth left. And the other thing that's interesting, notice how the occlusal plane rotates counterclockwise with growth without doing any orthodontic treatment. Anterior crossbite obviously doesn't resolve with growth. And these growth forecasts are also helpful in teaching parents and patients about future outcomes without doing orthodontic intervention, because they're always like, oh, well, won't Susie grow out of it? No, she's not going to grow out of it. So here's her frontal, and for purposes of cephalometric analysis, you need to flip it to turn into a PA ceph. And you have to do this with every one if you're going to do a frontal analysis using cone beam. You note the narrow maxilla, the narrow maxillary arch form, and the wide mandible, which is only going to get wider with growth. So a treatment plan for this patient is a bonded RME, occlusal coverage, expand about 6 millimeters, refer to an ENT for tonsil and adenoids, band and bond the upper arch, level the line, create space for the maxillary canines, eventually get going on the lower arch, and then retain with Hollies, and then do phase 2 treatment later when the rest of her teeth come in. So this is our initial pan. And this just happens to be a scan that I took at the time of RME removal. It just kind of shows the changes in the canines just with the expansion. And I'll get brackets on these lateral incisors about 4 months after the scan and tip those roots a little bit more to the mesial. And this just happens to be her diagnostic where we started from. And here's her lateral the day that we took out the expander. Note the improved change already in the cervical spine. And she hasn't been in to see the ENT yet, but just opening up that airway is helping. There she is from the front, diagnosis to RME removal. And you can see the canines just dropping down nicely here. So here's our young patient 17 months after the start of treatment, or about 10 months after I took out the expander. I placed open coil springs on the arch wire to start creating space for the eruption of the canines and increase overjet. You can see on the right side of the buccal. And then here we are about 3 months later at interim D-band. By the way, note her neck posture, much better than before. There's Here's our diagnostic pan to where we ended up at intro D-band. You can see now that the molar is well situated in the alveolus. Very nice angulation. Look at the incisors. Better placement in the alveolus. Here's her lateral ceph at the time of interim D-band. And there's her three-dimensional airway analysis. Notice that we're all the way up here in this end of the spectrum. Straighter cervical spine. Remember, that's where we started from. Frontal. Once again, there's her airway, post-treatment. And that's where we started from. So progress, lateral ceph at this point in time. You'll note the changes in the maxillary central incisors. All horizontal growth now is kept pace with each other, both the maxilla and the mandible. She's still got quite a bit of growth left, but we got her out of the anterior crossbite. And one of the neat things with CBCT imaging, you can do three-dimensional superimpositions before and after. So this is before treatment. Watch the airway over here and watch everything that goes on here. It's pretty cool. But you can see the straightening of the spine right there with those superimpositions. There's her frontal. You note the maxilla is much closer to where it should be in width. You can see how that upper maxillary first molar moved that out to the buccal. Notice the mandible got wider with treatment as well. So here's our three-dimensional superimposition of the frontal. And watch the lower third of this nasal cavity after expansion. Increases in width. So our patient at the end, after 20 months, just a couple of comparisons here. Upper arch form before to where we finished up. And there she is from the frontal. And then that right lateral view. And this is her 2 years later. Just like